This is chapter 44 of NUR 203, The Child with Cancer. You have 11 objectives for this chapter that you can read and follow along with. Cancer in children in the United States is rare unless your child is one who has it, and then it's the only thing in the world that really matters. Relatively low incidence, approximately 1,300 deaths per year. The incidence of 18 cases per 100,000 children. So cancer in children in the United States is rare, but like I said, if your child has it, it doesn't seem so rare anymore. Genetic alteration leads to unregulated cell proliferation. It's not necessarily hereditary, but we know that now they've discovered that certain genes that we carry may make us more apt to get cancer. Mutation in tumor suppressor gene chromosome abnormalities contribute to development of cancer, and the immune system conditions may contribute to cancer. St. Jude's Children's Hospital in Memphis, Tennessee is always working to find cures and is a wonderful organization if your child has cancer or not, because a lot of us need to, have a charity that we want to contribute to, and I've personally contributed to them because I think they're a great organization. So children who have been exposed to or have things on this list are apparently at higher risk. Exposure to radiation, carcinogenic drugs, immunosuppressive therapy, infections like Epstein-Barr virus. Your race, if you're Caucasian, you're at higher risk, and boys are at higher risk more than girls. Genetic conditions like Fanconi anemia, Widerman syndrome, neurofibromatosis type 1, ataxia, telangiectasia, and Klinefelter syndrome are also genetic conditions that predispose you to cancer. Cancer prevention, educating regarding known carcinogens. Provide early intervention. I posted in your assignments about how to teach breast self-examination and testicular self-examination, and when women should have pap smears. Early recognition would be fever and pain common in childhood, leading to easily missed problems. Unexplained loss of energy, sudden vision changes, and excessive rapid weight loss. See page 1300, box 44.1 for the cardinal symptoms of cancer in children. We would do a diagnostic evaluation, including a history and physical. Laboratory tests like CBCs and LFTs, coagulation studies, urinalysis. Diagnostic procedures like a lumbar puncture, bone marrow aspiration, and diagnostic imaging, surgery possibly, and a pathologic evaluation with a biopsy. Cancer treatment, there's multi-modalities with combination of surgery, chemo, and radiotherapy. Surgery to remove traces of the tumor and restore normal function, and chemo is the primary form of treatment. But they usually use a combination of drug regimens. IV infusion through venous access devices, and precautions would be experienced and trained nurses. You have to be chemotherapy trained to work on a cancer unit and give chemo. Radiotherapy in conjunction with chemotherapy. And see page 1302, table 44.1 for early side effects of radiotherapy. Biologic response modifiers alter the host immunologic mechanisms and direct anti-tumor effect. Blood or bone marrow transplantation, used in high doses of chemotherapy or replace dysfunctional marrow. Cells previously stored are given IV after conditioning regimen. Complications of therapy, see page 1303. Pediatric oncological emergencies, tumor lysis syndrome, and hyperleukocytosis. You can read about more in your books. Superior vena cava syndrome, they would have cyanosis of the face, neck, and upper chest, facial edema and distended neck veins, airway obstruction, including wheezing and dyspnea, protect the airway and reduce respiratory distress. Spinal cord compression, tumors press on the spinal cord sometimes. There's back pain, extremity weakness, loss of bowel and bladder function, and they treat this with high-dose steroids and radiation. Care management, quality patient outcomes guide care. See page 1304 for quality patient outcomes. The child with cancer. Early detection is critical to early treatment and cure. Signs and symptoms would be pain, fever, ecchymosis, petechiae, spontaneous bleeding, lethargy, weight loss, general malaise, anemia, firm and enlarged lymph nodes, and vision changes. Managing the side effects of treatment. Damage occurs to normal tissues as well as it does to malignant tissues. Infection, we need to monitor for septic shock. Fever, absolute neutrophil count lower than 500. Usual signs of infection and inflammatory response is limited. Collect specimens for evaluation. Start broad-spectrum antibiotic therapy. Reduction of infection risk using cerebrospinal fluids, and prevention of infection is a priority. Hemorrhage can be prevented or controlled with platelet infusions. Platelet infusions generally reserved for active bleeding not responding to basic treatment measures. Repeated transfusions increase risk of sensitization and antigen formation, and teach them to avoid activities that may cause injury like bicycles and skateboards and contact sports. Anemia is a common duration induction therapy. It's common in chemotherapy. Limits tolerance of physical activity. It kind of wipes them out. There's nausea and vomiting, and it can be intense. Antiemetics, especially Zofran, seems to be the drug of choice for chemo patients. It's used to manage the side effects. And synthetic cannabinoids are being used in children. Administer antiemetic 30 minutes before chemo begins and routinely for 24 hours after chemotherapy. Alteration in nutrition, monitor intake and nutritional status, monitor their height, weight routinely, monitor their pre-albumin, transferrin, and albumin levels. They should have a high protein, high calorie, full fat rather than reduced fat option for their foods. Mucosal ulceration is also a side effect. Red, eroded, painful sores in the mouth may extend to the rectal area. Increased anorexia due to pain. We should use bland, soft food, moist, and soft sponge toothbrush. Mouthwashes, helpful. Avoid viscous lidocaine, and sitz baths are helpful for the rectal lesions. Neurologic problems would lead to severe constipation. Monitor their stool habits and administer stool softeners. Foot drop is a problem. Weakness and numbness lead to difficulty in walking. Severe jaw pain can be managed with analgesics, and children may decrease oral intake. So some of them end up with tube feedings because it's too painful to eat orally. Hemorrhagic cystitis, prevented with at least 1.5 times recommended the daily fluid intake. Encourage frequent voiding. Watch for dysuria and hematuria. And of course, with chemo, we expect them to have alopecia. And we need to warn the child and family of the possible side effect and allow them to prepare themselves mentally for this. The hair will fall out in clumps, and it leads to patchy baldness. So that's why a lot of people will just go ahead and shave their whole head when their hair starts to fall out. They may choose to cut it short or shave it. The hair regrows in 3 to 6 months. It often comes back a different color and consistency. Where they had straight hair before, it may be curly this time when it comes back in. Steroid effects can be distressful for older children. They get the cushingoid appearance, like the Michelin Man. Avoid salt intake to reduce fluid retention, and let them wear loose-fitting clothes. That helps hide their appearance. Nursing care during blood or bone marrow transplant. They're hospitalized for several weeks. There is an insertion of a venous access device. Strict infection precautions. Most common complication is graft versus host disease, where the patient's body will reject the graft. Blood products would be irradiated to minimize additional antigens. Typically, they're sedated before the procedure. Explanations according to age and development are provided. Emotional support. Topical anesthetics before venipunctures like Emla cream and accessing implanted ports. Deeper infiltration of lidocaine used for bone marrow biopsy. Pain management. Use the World Health Organization's 3-step analgesic pain ladder. Extensive understanding of opioid and non-opioid analgesics. Interdisciplinary pain teams provide consultations and expertise. And doses are titrated to increase analgesia and minimize side effects. Health promotion. Children with cancer still need basic health care. That can be overlooked with focus on the cancer care. Cognitive, physical, and neurologic status is carefully monitored. Their dental care needs to be paid attention to. Fluoride and dental examinations. Monitor for effects of irradiation. May have a delay in development of their permanent teeth. For immunizations, the live and attenuated viruses are contraindicated. Inactivated viruses or vaccines can be used. The family can receive some live vaccines. Varicella is dangerous to a child undergoing chemotherapy that has cancer, and they need varicella immune globulin instead. Education for the family is constant and ongoing. Be aware that some families resort to unproven treatments. They're desperate. They're willing to try anything to save their child. Direct families to local and state medical societies for information. The American Childhood Cancer Organization is a great one. And educate to maximize compliance. Cessation of therapy. Late effects occur after treatment has ended. Nurses assess for late effects. Families need education about continued medical care, and other healthcare professionals need informed about the diagnosis. Genetic or infertility counseling may be needed as the child grows to maturity. Leukemias. I've posted on our site on Canvas about leukemia. Please look at those other things that I posted besides just your chapter PowerPoint. Leukemias, acute leukemias, a broad group of malignant diseases of bone marrow and the lymphatic system. Complex disease with varying heterogeneity, and classifications are increasingly complex. Morphology: acute lymphoid leukemia, acute non-lymphoid leukemia, and stem cell or blast cell leukemia, all of which I have posted extra videos to go along with this PowerPoint. Leukemia is an unrestricted proliferation of immature white blood cells in the blood-forming tissues of the body. The liver and spleen are the most severely affected organs, and leukemia demonstrates the same neoplastic properties as solid tumors do. Although leukemia is an overproduction of white blood cells, often acute forms cause low leukocyte counts. There's greatly elevated immature cells or blast cells. Immature cells do not attack and destroy normal blood cells. The cellular destruction takes place by infiltration and subsequent competition for metabolic elements. Bone marrow dysfunction: proliferating cells decrease bone marrow production due to the competition for essential nutrients. There are three primary consequences. You have anemia, infection and neutropenia, and you have bleeding. Bones weaken and are prone to fractures. The bone pain from increased pressure, though, is what we often see in children. They complain of bone pain, particularly in their legs. Signs and symptoms would be fever, pallor, fatigue, anorexia, hemorrhage, and bone or joint pain. Disturbance of the involved organs, the spleen, liver, and lymph glands, demonstrate infiltration, enlargement, and fibrosis. Use of prophylactic CNS intrathecal therapy. Intrathecal meaning it's going directly into the spinal column. Decreases CNS relapse. Other sites include cranial nerves, spinal nerves, and signs and symptoms relate to the nerves that are involved. Diagnostic evaluation of leukemia is based on history of physical manifestations. Minor infection does not disappear. They will be pale, listless, irritable, febrile, and anorexic. Peripheral blood smear may show immature leukocytes, and frequently they'll have low blood cell counts. They'll do a lumbar puncture to evaluate central nervous system involvement. And a bone marrow aspiration or biopsy would be done. For the management of leukemia, there's IV and chemotherapy. 3 phases of therapy. Induction is the first 4 to 5 weeks, and that would begin immediately. Intensification or consolidation therapy is done to eradicate residual leukemic cells, and that would be chemotherapy given periodically over 6 months. Maintenance therapy is to preserve remission, and that's weekly or monthly CBCs. Treatment usually stops after 2 to 3 years, and then they monitor for relapses. CNS prophylactic therapy is used in high-risk children to reduce the risk of leukemic cells taking over the central nervous system. Reinduction after relapse. Each relapse means a poorer prognosis for this child. Tests are resistant to chemotherapy and may lead to relapse. Relapse in the testes lead to intensive chemotherapy and irradiation. Bone marrow transplants are used in all ALL and AML leukemias. Care management: you need to prepare the family for diagnostic and therapeutic procedures and provide continued emotional support. Lymphomas. Also posted on your site on Canvas for this week about Hodgkin's and non-Hodgkin's lymphoma. Please make sure you look at those also. Hodgkin's is more prevalent among children 15 to 19 years of age. Non-Hodgkin's is more prevalent among children under 14. With Hodgkin's, it's neoplastic disease originating in the lymph system, primarily involves the lymph nodes, often metastasizes though to the spleen, liver, bone marrow, lungs, and other tissues. These are the main areas of lymphadenopathy and organ involvement in Hodgkin's disease, and you can see this picture on page 1312 in your chapter. There are 4 types of Hodgkin's disease: lymphocytic predominance, nodular sclerosis, mixed cellularity, and lymphocytic depletion. Staging and prognosis. Accurate staging is the basis for treatment and prognosis. There's more than one staging system available. Improved treatment and staging has improved the survival rate. And you can see box 44.2 and 44.3 in your chapters for staging of Hodgkin's and non-Hodgkin's lymphoma. Diagnostic evaluation of Hodgkin's. Clinical manifestations: painless enlarged cervical or supraclavicular lymphadenopathy, a cough, abdominal discomfort, and anorexia. There would be fever, anorexia, weight loss, and night sweats. And the diagnostic evaluation would include the history and physical, CBC, uric acid liver function, a CRP or ESR, alkaline phosphatase, urinalysis, and radiologic test. The lymph node biopsy would be sent for presence of Sternberg-Reed cells. The treatment would include radiation, chemotherapy alone or with radiation. The prognosis, long-term survival, is excellent. Aggressive therapy increases the chances of complications. Care management, preparation for diagnostic procedures, side effects, family support, and concern for high risk of infertility. Non-Hodgkin's lymphoma occurs more frequently in children than Hodgkin's disease. Clinical appearance: the disease usually is diffuse rather than nodular. The cell type undifferentiated or poorly differentiated, and the dissemination occurs early, often, and rapidly. Mediastinal involvement and invasion of the meninges. This is not a good outcome for children. Staging and prognosis. The staging is based on histologic presentation. Staging has little value in non-Hodgkin's lymphoma, other systems developed. Prognosis improved with young age, low mediastinal involvement, low tumor burden, and good response to initial therapy. Clinical manifestations depend on anatomic site that's involved. Metastasis to bone marrow or CNS may appear like leukemia. Diagnostic evaluation: surgical biopsy for confirmation, bone marrow aspiration, radiologic studies, CAT scan of the lungs and the GI system. Care management: aggressive irradiation and chemotherapy, induction, consolidation, and maintenance, and some intrathecal chemotherapy would be required. Also, primary focus on managing the effects of the chemo. Nervous system tumors, brain tumors. Brain tumors are the most common solid tumor in children. Specific cells may be involved. They may be benign or they may be malignant. Signs and symptoms are related to anatomic location and size. Hydrocephalus may be an indication. Headache. Children do not often get headaches unless they're play acting like they saw mommy complaining, "Oh, I have a headache." But children do not usually complain of a headache. Take it seriously if they're not pretending. Vomiting, nystagmus, ataxia, dysarthria, diabetes insipidus, and growth failure. And you can see page 1316, table 44.2, for the clinical manifestations and assessment of brain tumors. Diagnostic evaluation, clinical signs and symptoms include using an MRI, diffusion-weighted imaging, spectroscopy, perfusion imaging, CT scan, a lumbar puncture, and biopsy. To treat it, they may do surgery, radiotherapy, chemotherapy. Treatment of choice is removal of the tumor without neurological damage, radiotherapy to shrink the tumor before removal, and chemotherapy alone or in combination. We're going to assess for signs and symptoms of a brain tumor, prepare the family for diagnostic and operative procedures, prevent post-operative complications, assess. Positioning would be important, fluid regulation, comfort measures, support the family, and promote return to optimum functioning. Neuroblastoma, the most common extracranial solid tumor, most common cancer diagnosed in infancy. Originates from embryonic neural crest cells. Primary site is in the abdomen. Clinical manifestations depend on location and stage. They would be firm, non-tender, irregular mass that would be felt in the abdomen. Neurologic impairment, respiratory obstruction, paralysis, periorbital edema, exophthalmos, supraorbital ecchymosis. Diagnostic evaluation would be done through CAT scan, bone scan, MIBG scan, bone marrow biopsies, and urinary catecholamines. Staging and prognosis. The diagnosis is often made after metastasis has occurred. Age and stage of disease impacts the prognosis. The younger the age, the more likely the survival, because the younger the baby is, the more stem cells they still have working to proliferate and regenerate things in their bodies. Look at staging of neuroblastoma in box 44.4. Therapeutic management would be surgery to remove as much of the tumor as possible, irradiation post-operatively along with chemotherapy. Care management, preparation for diagnostic and operative procedures, prevention of post-operative complications, educate the family about chemotherapy and radiotherapy, evaluate coping, and provide support. General considerations account for about 6% of all malignancies in children. Osteosarcoma is most common type of bone tumor. Bone tumors, clinical manifestations, localized pain at the affected site, severe, dull, sometimes attributed to growing pains. One of my sons complained he had growing pains in his legs off and on when he was growing up, and I was told that that was growing pains. Thank goodness it wasn't anything more serious, because he was growing so fast his bones couldn't seem to keep up. He was tall. Limping, decreased physical activity, unable to hold heavy objects, a palpable mass, fever, and respiratory distress. The prognosis is great. Most can be cured. The diagnosis is a thorough history and physical. Rule out any trauma or infection. Functional status of the affected area. Look for signs of inflammation and the size of a mass, if there is a mass. Are they anemic? Have they been losing weight? Do they have any infections? X-ray, CAT scan, MRI, and a biopsy. Osteosarcoma likely arises from bone-forming mesenchyma, found mostly in the lower extremities near the growth plate. Therapeutic management, surgery and chemotherapy. Surgery for biopsy and to save or amputate the limb. Limb salvage includes a prosthetic bone placement and chemotherapy to decrease the tumor size. Care management depends on surgical approach, whether they salvage or amputate. Prepare the family for surgical intervention and outcome. Allow the child to ask questions and expect them to go through the grief process. Answer the questions but do not offer extensive information. Inform the child of the chemotherapy effects. Do not offer too much at one time. Phantom limb pain may develop. Start discharge planning early, physical therapy, and assist with clothing choices. Ewing sarcoma arises in the marrow spaces. It originates in the shaft of the long and trunk bones, the pelvis, femur, tibia, fibula, humerus, ulna, vertebrae, scapula, ribs, and skull. Therapeutic management, limb salvage or amputation depending on the situation, along with radiotherapy and chemotherapy. Care management does not necessarily lead to amputation. Prepare the family for diagnostic tests. Wear loose-fitting clothes over irradiated area. Protect the irradiated area from sunlight and sudden temperature changes. And prepare the child for effects of chemotherapy. Other solid tumors, the Wilms tumor is the nephroblastoma, the most common kidney tumor in childhood. Rhabdomyosarcoma is the most common soft tissue sarcoma. You can see this on page 1322. And retinoblastoma arises from the retina and is the most common intraocular malignancy of childhood. These children end up with an enucleation and a prosthetic eye. Wilms tumor, most common kidney tumor of childhood. Clinical manifestations, a painless swelling or mass in the abdomen. There's a firm, non-tender, confined to one side deep within the flank area mass that's felt on palpation, often discovered during routine hygiene cares. Stop palpation immediately if you feel a mass in the abdomen and notify the physician. You would want to put a sign over the bed that says, "Do not palpate abdomen." Because this tumor is somewhat encapsulated, the more you manipulate it, the more you are apt to burst it, and then the cells would be free to run wild in the body, so we don't palpate. Diagnostic evaluation, history and physical exam, signs of malignancy, ultrasound, CAT scan, MRI, CBC, and urinalysis. Staging and prognosis. If unfavorable histology, then the prognosis is poorer. Survival rates are highest among all childhood cancers. Therapeutic management, surgery and chemotherapy, may or may not have radiation. Care management is similar to that of other cancers. Preoperative care, surgery usually occurs within 24 to 48 hours of diagnosis. The challenge is to prepare the family and the child for surgery that quickly. Do not palpate the tumor. Careful bathing and handling of the child is important, and tell the parents what to expect and keep the terms simple. Post-operative care recovery is generally rapid. Typical cares following abdominal surgery, monitor bowel function, and monitor for infection. Support the family. This is a difficult time. Provide support through understanding of information. Therapeutic play for older children. Rhabdomyosarcoma is the most common soft tissue sarcoma in children. Most common in children 9 years and under. It arises from embryonic mesenchyma. Clinical manifestations are signs and symptoms related to the site of the tumor and compression on the organs around the tumor. There may be an earache or runny nose. Diagnostic evaluation, history and physical, of course. A PET scan, a CAT scan, or an MRI. Biopsies, and an LP, lumbar puncture. Staging and diagnosis, important for planning treatment. Multimodal therapy demonstrates high survival in the non-metastatic disease. So therapeutic management, multimodal, more than one type of treatment. Complete removal of the primary tumor and chemotherapy. Care management is similar to other types of cancer. Preparation for multiple diagnostic tests and surgery, and supportive care of the family. Retinoblastoma arises from the retina. May be caused by genetic alterations. Clinical manifestations. Few obvious signs, but this is the one where when you're looking for the red reflex and you shine a light into the child's eyes to check for a red reflex, you get no red reflex. In fact, you get a whitish glow instead of a red flash in the pupil. Strabismus and blindness later on. Diagnostic evaluation, detailed family history, ophthalmos. They'll use an ophthalmoscope to look at the eye. Ultrasound, CAT scan, and MRI. Staging and prognosis is done prior to surgery to determine the size and location, and long-term concern in secondary tumors. Therapeutic management, irradiation, chemotherapy, a surgical implant of iodine-125 for radiation, photocoagulation, and cryotherapy. Care management, prepare the family for diagnostic and therapeutic procedures, and home care and support the family. Germ cell tumors account for 14% of all tumors in children 15 to 19 years old. Teratoma is most common type in childhood. Most common ovarian tumors are mature cystic teratomas. Most teratomas are localized and gonadal, surgically resected without further therapy. Care management, teach testicular self-examination to all adolescent males, teach symptoms to report, and teach normal findings with their own anatomy. Liver tumors, surgical resection is treatment of choice, surgery often done after chemotherapy, liver transplant used when resection is not possible. The childhood cancer survivor, 5-year survival rate is 80%. That's great. Complications common with combined treatment modalities. Late effects are of concern, changes related to treatment, interactions between treatment modes, and effects may occur months to years later. Radiotherapy can decrease growth in bones and reproductive organs. Treatments may cause hormonal dysfunction. Growth and Tanner stages are important to document and assess all body masses and areas for abnormalities based on treatment used. This concludes this chapter. This slide presentation is very thorough, and with these slides and the chapter in your book, along with the other things I posted on Canvas, you should not have any problems with this chapter. The end.